We are so happy to have you joining us today, Dr. Patel.
Thanks so much for having me, Dalton, and thanks to everyone for logging on and spending some of your summer with me. So with that, I will go ahead and share my screen. Uh, and is are the slides popping up okay?
Yep, they look great.
Excellent. Great. Well, my name's Anand Patel. I am a faculty member at the University of Chicago, and I focus on taking care of patients with myeloproliferative neoplasms, myelodysplastic syndromes, and acute leukemia predominantly. I also have an interest in trying to develop novel therapies for kind of high-risk populations within those diseases. So the topic for today, I think, is a very interesting one, and I think it's one that oftentimes we kind of gloss over in the clinic when talking to patients. So I'm glad I really have a chance to dive deep in it with all of you. And really, what we're going to be talking about over the next 30 minutes or so is myelofibrosis explained, and really what primary myelofibrosis is versus secondary myelofibrosis. These are my disclosures. And I do mention a couple clinical trial sort of therapies. So I will mention if there are drugs that are not um, currently FDA approved for one indication or another. So really, the objective is to start by providing a general overview of MPNs. I think it's important to kind of know where you're starting before you think about where there could potentially be progression. We'll then move into how we make a diagnosis of primary MF versus secondary MF. We'll also talk about the various prognostic scores that we use for these different conditions. And then lastly, we'll focus a little bit on treatment, specifically the role of JAK inhibitors and then allogeneic transplant in the management of MF, both primary and secondary. So, to kind of set the stage, when we think about what we refer to as our pH negative MPNs, so people that don't have a Philadelphia chromosome, really there's three major disease states. There's polycythemia vera, with the major issue there being that your hemoglobin and hematocrit are too high. So that puts you at risk of having clotting complications. So the goal is to try and reduce the hematocrit into a healthy range. And when we do a bone marrow biopsy, we kind of see that there's increased growth of white blood cells, red blood cells, and platelets. Almost all patients with polycythemia vera have a mutation in a gene called JAK2, which is the most common mutation that we see in MPNs. Next, we have essential thrombocythemia, or ET. And really, the major issue here is that there's an elevated platelet count. And again, that platelet count can put people at risk of having clotting complications, particularly if they have other risk factors for blood clots. When you do a bone marrow biopsy in someone with ET, the main thing you see is that they have too many platelet precursors, otherwise known as megakaryocytes. Most patients with ET have a JAK2 mutation, with another 30% of patients or so having a mutation in CALR or MIPL. So those three mutations together are what we call our driver mutations that we typically see in MPNs. And when patients don't have any of those three, we tend to refer to that as triple negative disease. And then last but not least, we have primary myelofibrosis, or PMF. And really, blood counts can be all over the place with PMF. It really depends on when someone presents to a physician in their journey. Early on with primary myelofibrosis, patients can have very high blood counts in what we call the cellular phase of PMF. But as the bone marrow gets more and more scarred or fibrotic, you can have normal blood counts or even low blood counts as the disease progresses. So if a bone marrow biopsy is done, you see lots of scarring or fibrosis, and you also see abnormal platelet precursors or megakaryocytes. And much like ET, most patients have a JAK2 mutation. Another 30% or so will have a CALR or a MIPL mutation, and then 5 to 10% of patients will have triple negative disease. So, what do we need to worry about when it comes to disease progression in myeloproliferative neoplasms? In my mind, I like to think of MPNs in three buckets. There's your cellular phase MPN, meaning the issues that you're dealing with are related to high blood counts. And really, the goal is to think about how to prevent clot, how to prevent progression of disease, and really that's the focus. You then have the fibrotic phase, chronic MPNs. So that is where primary myelofibrosis that's in the fibrotic phase or secondary myelofibrosis kind of falls. And really, in those patients, the question you have to ask is the disease high risk enough to where we need to be thinking about an allogeneic transplant to try and cure the disease? And then in patients who have a large spleen or other symptoms, they may benefit from being on a JAK inhibitor. And then the last kind of bucket is accelerated or blast phase MPNs. So thankfully, this is a rare complication of MPNs, but it does happen. And this is where MPNs start to behave more like an acute leukemia or an aggressive leukemia. So really the goal there is to think about using chemotherapy type strategies that you would for acute myeloid leukemia, which is a aggressive leukemia that accelerated and blast phase MPNs behave like, and trying to get to a stem cell transplant if appropriate. So where do PMF and secondary myelofibrosis fall into all of this? So as I mentioned earlier, patients can have myelofibrosis and still be in what we call the cellular phase of disease. So if you catch someone with early primary myelofibrosis or PMF, they still may be in that left bucket of cellular phase. And depending on how the disease progresses, they may then progress into the fibrotic phase bucket, which is where secondary myelofibrosis kind of lives as well. So how do we make a diagnosis of primary myelofibrosis? So I really like this slide because it makes that very clear differentiation between early primary myelofibrosis, which we refer to as pre-fibrotic or cellular stage, and then overt fibrotic stage, meaning scarring is the main thing that we're seeing. So when you're thinking about early primary myelofibrosis, the things that we look out for is that there's fibrosis, but there's not a overwhelming amount of fibrosis. So on a scale of 0 to 3, the fibrosis is less than 2. So it's either grade 0 or grade 1 myelofibrosis. There are some criteria that you need to meet to make sure that you don't have other myeloid cancers that could be mimics for primary myelofibrosis. And then there are minor criteria such as an elevated blood count, low hemoglobin, palpable splenomegaly, or an LDH level. Now, when patients have what we call the overt fibrotic stage, really the big difference between early stage and fibrotic stage is the amount of fibrosis or scarring. So these patients have either grade 2 or grade 3 fibrosis in the bone marrow. And again, that's out of a 3-point scale. So 0, 1, 2, or 3. But the other criteria are very similar. Now, let's dive into the different types of secondary myelofibrosis. Now, the two most common types of secondary myelofibrosis are post-PV myelofibrosis and post-ET myelofibrosis. So we're going to focus on post-PV myelofibrosis first. So as mentioned, the diagnosis for PV really relies on having an elevated hemoglobin or hematocrit. Almost everyone has a JAK2 mutation. A bone marrow biopsy should be done to kind of look for increased production of all three types of blood cells. And then many patients will have a low EPO level. EPO is the hormone that signals the body to make more red blood cells. So in PV, the body kind of senses that the issue is too many red blood cells. So it'll turn that EPO level down. Now, for patients with post-PV myelofibrosis, really the big criteria are they need to have a established diagnosis of PV and a bone marrow biopsy that shows grade 2 or grade 3 fibrosis. Now, one of the major takeaways I'd like for you all to have today is it is absolutely essential in my mind to get a bone marrow biopsy at the time of diagnosis or suspicion of an MPN, because that is what gives us that starting point of how much fibrosis is there, what other abnormalities are we seeing. And that way, if and when a bone marrow biopsy is needed down the road, we have a very clear comparison point. The other reason that matters is, as I mentioned earlier, primary myelofibrosis in the early stages can mimic PV or ET. So without getting a bone marrow biopsy, it's really impossible to differentiate. And now post-ET myelofibrosis, which is the other type of secondary myelofibrosis. So for ET, the major diagnostic criteria are an elevated platelet count, a bone marrow biopsy that shows increased megakaryocytes, which are the platelet precursors, and then you need to rule out other sorts of blood cancers and the presence of one of the common mutations that are seen. And much like post-PV MF, really the diagnosis for post-ET MF is based on someone being diagnosed with ET previously and then having a bone marrow biopsy that shows grade 2 or grade 3 fibrosis. Again, the reason this matters is the trajectory of someone's disease is different based on where they start. So it's very critical to know, does someone have primary myelofibrosis from the get-go, or is this truly an ET or a PV that can kind of be managed, and the risk of it progressing to a secondary myelofibrosis is quite low over many, many, many years. Whereas with primary myelofibrosis, the risk of progressing from that cellular phase to the fibrotic phase is quite a bit higher. So the question that I think most of y'all are probably thinking about is, does it matter if someone has primary myelofibrosis versus secondary myelofibrosis? So this was a study that was published a few years ago. And really the big takeaway is um, they are somewhat different diseases, primary myelofibrosis or secondary myelofibrosis. So the table below shows what factors impact survival. So for primary myelofibrosis, age over 65, a low hemoglobin, a low platelet, blast cells in the blood, or symptoms impacted survival. But for post-PVMF, it was really the hemoglobin, age, and symptoms. And for post-ETMF, it's really your platelet count and the presence of blasts or immature cells in the blood. The other thing that we noticed is when you kind of look at how patients do over a period of time, post ETMF, which is this red line, tends to have the best overall survival. And it kind of makes sense because ET of these three diseases tends to be the most slow moving and indolent. But post PVMF and primary myelofibrosis behave very similarly. The lines are basically superimposed upon one another. Now I'm going to talk a little bit about how do we assign a prognostic score to patients with primary myelofibrosis. So over the last 15 years, we've come a long way in our prognostic scores. Originally, we had the IPSS and the dynamic IPSS, which just used clinical lab values. We then had the DIPS Plus that incorporates cytogenetics, so chromosomal abnormalities. And now we live in what I call the molecular era of MPNs, where it matters what mutations are in your MPNs as well, because those are needed in your risk scores. Now, one thing to note is all of these scores, with the exception of the MySEC PM, were developed in patients with primary myelofibrosis. So the only score that specifically was made for people with secondary myelofibrosis is this MySEC PM score. So then that begs a question, well, just because these scores were only studied in primary myelofibrosis, does that mean that they're not effective at assigning risk for people with secondary myelofibrosis? And the short answer is the DIPS Plus and the MIPS 70 version 2.0 actually work very well for secondary myelofibrosis and may even be better than the MySEC PM score. So you can still use the DIPS Plus or the MIPS version 2.0 for someone that has secondary myelofibrosis. And of course, you can use it for those that have primary myelofibrosis. So the MySEC PM for secondary myelofibrosis, as I mentioned, it was a specific score developed for secondary myelofibrosis. And these are kind of the variables that give someone points. So your age, how low your hemoglobin is, how low your platelets are we seeing these immature blast cells in the blood? Do you have a CALR mutation? And then symptoms. And then that can stratify patients into buckets of what we call low risk, intermediate risk, or high risk, which is delineated on the right in the chart that's shown. Now, as I alluded to, there's actually data to support that we can use our primary myelofibrosis scores in secondary myelofibrosis. So basically, when we use the DIPS plus in secondary myelofibrosis, it works very, very well. And the way we know this is when you look at what's called a C index here. So the closer you are to one, the better. And the DIPS plus actually has the best C index of any of these scores. So that tells us that even compared to MySEC PM, which is specifically developed for secondary myelofibrosis, the DIPS plus seems to be a very, very good score to use. And by that same token, if you're had molecular mutations checked either at diagnosis or when there was progression to myelofibrosis, you can further refine things and use the MIPS 70 plus version 2.0. Again, we're looking at what's called the C index, and the closer you are to one, the better. and the MIPS 70 version 2.0 has a C index of 0.79 compared to the MySec PM, which is 0.73. So the DIPS Plus and the MIPS 70 version 2.0 both work very, very well at assigning a prognostic score for patients with secondary myelofibrosis. So now let's talk a little bit about management. And when we think about clinical management of primary versus secondary myelofibrosis, I will say, practically speaking, our management does not change a whole lot based on whether someone has primary or secondary myelofibrosis. We calculate a risk score. If someone has intermediate or high risk disease, we think about a JAK inhibitor if their symptoms. We think about clinical trials. And if they are someone that's interested in a stem cell transplant, we will refer them for transplant evaluation. On the other hand, if people have no mutations that are high risk and don't have any symptoms, we just keep a close eye on patients. And we don't necessarily have to start something like a JAK inhibitor. And the four JAK inhibitors that we have approved currently for myelofibrosis are ruxolitinib, fedratinib, pacritinib, and momelotinib. So let's talk a little bit about the data that led to the approvals of these drugs. And the major point I want to make as we go through this data is for the patients that were treated on study, both primary and secondary myelofibrosis was allowed on study. So all of these JAK inhibitors show benefit in myelofibrosis kind of as a big category. You don't necessarily have to worry about, is a JAK inhibitor less likely to work for me because I have primary myelofibrosis versus secondary myelofibrosis. So for the Comfort 1 study, which was the study that led to the approval of ruxolitinib, intermediate 2 or high risk myelofibrosis, a large spleen, platelets over 100, and having less than 10% blasts in the blood are kind of what were needed to be able to go on study. And the goal was to reduce the spleen size by 35%, and that was achieved in about 40% of people on ruxolitinib and virtually no one who just received placebo. Now, Comfort 2, a very kind of similar study, with the main difference being that patients could receive what's called best available therapy. So any therapy that their physician felt like they would benefit from if they were not on the ruxolitinib arm. Still a positive study. About a third of patients on the ruxolitinib arm achieved the reduction in spleen size, and no one in the best available therapy arm achieved a reduction in spleen size. I should say a 35% reduction in spleen size. Next, we have fedratinib, which is the second JAK inhibitor that was approved. And this was from a study called Jakarta, which again looked at intermediate 2 or higher myelofibrosis, and that could be primary or secondary myelofibrosis. You needed to have a large spleen that could be felt on exam, and your platelets had to be at least above 50,000, with the primary endpoint being a 35% reduction in spleen size. And again, that was seen in about 40% of patients that were treated with fedratinib. They looked at a couple different doses of fedratinib, but about 40% of patients achieved this landmark. And then another study of fedratinib, specifically looking at patients that had already been treated with a JAK inhibitor previously. So this was a phase 3 study called the Freedom 2 study. And here it shows that fedratinib is very effective even in patients who previously were already on a JAK inhibitor. Next, we have pacritinib. So pacritinib is a JAK inhibitor that I would say is more or less specifically developed for patients who have low platelets and need to be on a JAK inhibitor. So these are patients who had a platelet count of under 100. They had a high burden of symptoms and had an enlarged spleen. And the co-primary endpoints were reduction in spleen size and reduction in symptoms. And really where that signal came out was in the patients with a platelet count of under 50,000. They're the ones that tended to benefit the most from pacritinib. There's an ongoing study called Pacifica that's looking at this in the context of a phase 3 study to really confirm the benefit of pacritinib. But currently, pacritinib is an FDA-approved option. And then lastly, we have momelotinib, which was studied in what we call the Momentum study. So this was really focusing in on patients with a low hemoglobin, a hemoglobin of less than 10, and looked at using momelotinib versus a drug called danazol, which can help improve your hemoglobin. And the first kind of endpoint or most important endpoint was making patients feel better. So 25% of patients had a reduction in their symptom score by 50% or more, and only 9% of patients in the danazol group. And then there are kind of several other components that they looked at, like the rates of transfusions were lower in the momelotinib patients. Oh, sorry. The spleen response rate was better, symptom score, and the rate of not needing transfusions for several weeks. Now let's talk about allogeneic transplant. So I think about allogeneic transplant in myelofibrosis as being a Goldilocks problem. You want to think about transplant when the timing is just right, meaning in patients with low risk myelofibrosis, they may not need a transplant for many, many, many years. And for patients with high risk myelofibrosis, they may ultimately be too sick to receive a transplant for one reason or another. So we really have to think about, when is someone's disease kind of approaching that advanced phase, but not so advanced that someone may be too sick or not benefit from a stem cell transplant. And this is how we think about both primary myelofibrosis and secondary myelofibrosis. So the decision making around allogeneic transplant is very, very complex. It's not a one size fits all approach at all. It's very personalized to the patient that's in front of you. And really, what it comes down to is risk score, how healthy you are to receive a transplant, and what features of your myelofibrosis are most prominent. Do you have a large spleen that needs to get shrunk down? Do you have other things like low blood counts that could maybe make a transplant harder, etc.? But, as you can see, there's several kind of criteria that you have to be thinking about when considering is transplant right for me. There's also a score called the MTSS, and this score really looks at how much is someone going to benefit from a stem cell transplant. And the big takeaway is this was studied both in primary myelofibrosis specifically, the MTSS, and it was very effective. And it was studied specifically in secondary myelofibrosis, so post ET or PVMF. And again, very effective. Getting back to this C index or C statistic that we've talked about. The closer to one, the better. And the MTSS score for patients getting a transplant was about zero point 0.7 for secondary myelofibrosis and about 0.72 for those with primary myelofibrosis. So worked better than many of the other scores we have available to us, specifically in patients that are receiving a stem cell transplant. So the other big question in myelofibrosis is the concept of disease modification. And this has been a hot topic for many years, predominantly because we don't have a good definition for what disease modification is. Most of our studies in myelofibrosis focus on spleen size and symptoms. But the question we have to ask ourselves is do we need to be looking at things beyond that, things that will help to potentially reverse someone's myelofibrosis and help them live longer and not just better? So those could be things like looking at molecular mutations and whether they go away with specific treatments. Many patients with myelofibrosis will have increased levels of cytokines, which cause many of the symptoms that they have. So if we have drugs that turn down the cytokines, will that help? Do we have a way to reverse the amount of fibrosis or scarring in a bone marrow? And then lastly, cytopenias or low blood counts. Do we have therapies that will improve someone's low blood counts? So in summary, cellular phase MPNs have a variable risk of progression to myelofibrosis. Um, I would very strongly advocate that if an MPN is being kind of suspected, a bone marrow biopsy should be done. A diagnosis of MPN should not be made on blood counts alone. Primary versus secondary myelofibrosis have their own specific diagnostic criteria. Our risk scores work quite well for both primary and secondary myelofibrosis. The four JAK inhibitors that we have available to us have included both primary and secondary myelofibrosis, so they seem to be beneficial in both. And then in general, for intermediate and high risk myelofibrosis, whether that's primary or secondary myelofibrosis, stem cell transplant or allogeneic transplant should be considered or at least discussed. So with that, thank you so much for your time, and I am happy to take questions. And here's
Great.
my email address and social media.
Awesome. That was super, super informative. So thank you for taking the time to share that with us. And as you mentioned, now is the time for our Q&A. So you can go ahead and place those questions in the chat. If you'd like to ask a question verbally, you can do so by raising your hand, and then I can go ahead and unmute you. But I jotted down a couple of questions to get us started here. So you mentioned that at the time of diagnosis, someone should get a bone marrow biopsy. How often after that initial bone marrow biopsy should people be getting them? Um, does fibrotic level change just
Great question. And in general, I don't have a specific interval at which I recommend doing bone marrow biopsies. It's really dictated by how someone is feeling and what their blood counts look like. So getting a biopsy at original diagnosis is critical. But I don't say get a bone marrow biopsy every 6 months or a year or anything like that. Really, what I'm looking for is, are someone's blood counts dropping in a way that's unexpected? Are they starting to develop a large spleen? Are there some kind of hints or signs that perhaps this cellular phase MPN is now turning into a fibrotic phase MPN? And that's what then would prompt me to get a repeat bone marrow biopsy.
okay? And then next up, I had, are transplants more effective in either primary or secondary myelofibrosis? Have there been many studies showing the overall impact of getting it primary or secondary? And are transplants ever considered for individuals with either PV or ET that have not progressed?
Yeah, great question. So, in general, the studies that look at transplant outcomes have lumped primary and secondary myelofibrosis together for the most part. And it does seem like they do about the same in terms of the success rate. Um, Now, with PV and ET, the main reason we don't consider stem cell transplant in someone with PV or ET is the risks of a transplant probably outweigh the benefits in someone with PV or ET. Their disease is probably a bit more slow moving when it's PV or ET. So really you have to think about, am I more likely to hurt someone with a stem cell transplant if they have PV or ET than I am to help them?
Okay, that makes a lot of sense. Um, Sanan, you can go ahead and ask your question.
Hello, my name is Sinan. I'm working in the University of Chicago as a research coordinator. Hi, Dr. Patel. I have a quick question. For the high-risk patients, we talked that we should consider the transplant as a treatment option. But I'm wondering, given the patient's age and the performance score, what's the rate that we are, moving forward for the transplant for our patients?
Yeah, that's a great question, Sinan, and I think you highlight something that's important, which is that even if transplant is something that we would recommend for a patient with myelofibrosis, that recommendation always has to take into consideration, is someone perhaps too sick for a transplant? Meaning, would a transplant be more likely to hurt them than help them? And there's not kind of again, a one size fits all approach. It's very patient specific, but things that we look at are age can be part of the discussion. Certainly, if someone has a very large spleen versus not, what other medical conditions they may have. So a lot of things that influence that decision to move forward with the transplant versus not.
Thank you.
And then we have more of a comment in the chat, but I'm going to go ahead and share it anyways. This individual has had myelofibrosis for 3 years, but they've recently started having more symptom burden, things like night sweats, nausea, and massive headaches. Would you recommend that now might be a good time for them to seek out a specialist, or what do you think an appropriate plan of action would be?
Yes, I would say in general, for patients with myelofibrosis who are on a stable regimen of medication or kind of surveillance, whose symptoms are worsening, that is probably the time to think about seeking out a specialist to see, for example, should we start a JAK inhibitor versus not? Should we be thinking about a repeat bone marrow biopsy? If someone's already on a JAK inhibitor, should we think about switching to a different JAK inhibitor? So certainly acceleration of symptoms is an important piece.
Okay. And if they are already seeing an oncologist, but they may not be sure if they're seeing a MPN specialist, can you just go quickly through how that second opinion or consultation process works? Since these are relatively rare conditions where really seeing that
Yeah.
MPN
And
specialist can be
and
beneficial.
absolutely. And I will say, I think the process of seeking a second opinion is never one that a hematologist or oncologist takes offense to. I think we're all looking to do the best for our patients, and that means if we need to ask for help, we ask for help. So given that MPNs are fairly rare diseases, really the way I kind of think of it is I have a luxury to focus on a very narrow scope of blood cancers and blood conditions. I don't have to know how to take care of myelofibrosis and lung cancer and breast cancer. So when I see someone with an MPN, typically what I do is I review their entire chart and story. We try to clarify anything that needs clarification. For example, we may request bone marrow biopsy slides from the original bone marrow biopsy to confirm the diagnosis, those sorts of things. And ultimately, if the recommendations are things that can be done by the oncologist or hematologist they're already seeing, we typically provide those recommendations and then they will continue to follow with that person. On the other hand, if it's something that's specific to my center, whether it's a clinical trial, whether it's consideration for stem cell transplant, et cetera, then we may end up kind of being more involved in the care of that patient moving forward. Even for my patients who end up following with their local hematologist or oncologist more closely, they're still checking in with me anywhere from once every 3 months to once every year or so, depending on kind of how frequently they're needing follow up.
Okay. That's really good to know because I think a lot of times they say I already have an oncologist, but if it's not a specialist, they may feel weird about going about getting that second opinion. So I think it helps a lot of people know that getting a second opinion is not frowned upon. Everyone kind of encourages that practice. And then next up, we have a question saying, is it possible for a person to have myelofibrosis but not be identified as either primary or secondary?
Yeah, so I mean, I think that question asks, could there be causes for myelofibrosis that are not actually related to an MPN? So there are patients, who have what we call autoimmune myelofibrosis. So scarring of the bone marrow, but not related to a blood cancer, but related to an autoimmune condition. So in general, if we think that someone's myelofibrosis is related to their MPN, then they would fall into either secondary or primary, depending on kind of where their MPN started. But outside of that, there are, yeah, causes like autoimmune myelofibrosis that aren't actually blood cancers and may need things like steroids or immune suppression, et cetera, because they may be more autoimmune conditions.
Okay. And then next up, this individual says that they've been on low-dose aspirin for their primary myelofibrosis. They've had several out of the blue symptoms like headaches, drops in platelets, leukoclastic vasculitis, bone pain, all intense but short-lived. Could Jakafi cause a greater drop in platelets?
Yeah, so Jakafi can absolutely drop your platelets. That's one of the major side effects we watch out for, and we usually adjust the dose of someone's ruxolitinib or Jakafi based on what their platelet count is. So certainly for patients who are on a JAK inhibitor, not just Jakafi, but kind of across the board, a close monitoring of platelet count is absolutely necessary.
Okay. And then this one is asking about anemia. So this individual had a stomach hemorrhage, anemia, splenomegaly, diagnosed with CALR 2 months ago. While healing with the hemorrhage, or will healing the hemorrhage make the anemia go away and shrink the spleen? So kind of getting to like root of symptoms, can that all be caused by the MPNs, by the myelofibrosis, or can there be other things that are contributing to anemia, contributing to like splenomegaly? Just how do you kind of parse through the root cause of these issues?
Yeah, so I think it's important for an MPN specialist to not have blinders on. I think it can be really easy for us to attribute everything to your MPN. But for example, if someone just had a hemorrhage, their anemia may not be because of myelofibrosis worsening. It may be because they just had an hemorrhage. And over the next 2 to 3 months, and perhaps if they need iron supplementation, et cetera, the anemia may slowly improve. I don't think, a hemorrhage would necessarily explain having an enlarged spleen. But we always do have to think about, could other things be causing blood count abnormalities that aren't related to the MPN?
Okay. And then next up, we actually have a couple questions that are relating to hydroxyurea here. So This individual was diagnosed a couple of years ago with ET. Platelets were 979. They have had a bone marrow biopsy and are on hydroxyurea since, but now they're stable around 700. But um, do you find that hydroxyurea is the best option in these sorts of cases? If bone marrow biopsy is showing more of a chronic phase, so they kind of that early grade 0 or grade 1 fibrotic, um, or do you think that it could be prudent to look into a JAK inhibitor at that level?
Yeah, so I mean, I think in general, JAK inhibitors are the most important to use for myelofibrosis when you have a large spleen or have symptoms. If you don't have a large spleen or symptoms, the JAK inhibitor probably won't benefit you all that much, and it may just reduce your other blood counts. Um, Now, early MF, things that you can think about from a treatment standpoint is you can use hydroxyurea to help control the high blood counts, particularly if you've had a previous clot. There have also been studies that are ongoing to see if there's benefit to starting a type of drug called interferon, with the hope that interferon may reduce the risk of someone's early myelofibrosis progressing to the fibrotic stage of disease.
Okay. And then this is actually a really good question that I've never thought of, but I'm really curious about. Are there any tests that can be done to distinguish if one's fibrotic bone marrow is attributed to cancer, like myelofibrosis, or from an autoimmune setting?
Yeah, so the main thing is doing the chromosomal testing and the molecular testing. So in general, patients with autoimmune myelofibrosis don't have chromosomal abnormalities or don't have molecular mutations. On the other hand, patients with an MPN, the vast majority of the time will at least have some sort of mutation that's found in their bone marrow. Even if it's not one of the three common mutations, JAK2, CALR, or MIPL, there are several other mutations that can be tested for and found.
Okay. And then speaking about those mutations, are there any clinical studies that are going on looking at targeting those specific mutations? So, like a CalR directed therapy or a MIPL directed therapy. So we have the
Yeah,
JAK
so
inhibitors, but
yeah, great question. So I mean, I think JAK inhibitors, the first point I'll make is JAK inhibitors work whether or not you have a JAK mutation because the pathway of JAK is overactive in MPN. So JAK inhibitors work even if you don't have a JAK2 mutation. Now, for the other mutations, CALR and MIPL, there's a lot of work being done to develop CALR targeting therapies, so antibodies, vaccines, all sorts of things. I'm not aware of any therapies that have yet been developed that target MIPL specifically.
okay. And then does escalation of symptoms always mean that myelofibrosis is progressing? This individual is not sure if they're primary or secondary.
Yeah, I would say it doesn't always mean that myelofibrosis is progressing, and I think again that's why you have to make sure that as an MPN doctor, we're not just chalking everything up to an MPN. I mean, a good example is I've had patients who have worsening symptoms, and ultimately it's because they have thyroid problems and not anything related to their myelofibrosis. So I think making sure that you're being broad about ruling out these other things before you chalk it all up to the MPN is important.
Okay. And then next one that rolled in. So um, let's see. So this one is asking about transfusions. So they sounds like they're on Ojara currently. They have been for about 5 months, but they're still needing transfusions every 2 weeks. They're exploring clinical trials currently, but they want to know if there's any clinical trials that may be able to help reduce symptom burden, or not symptom burden, kind of that burden of transfusion. Is that something that's looked at often, of how often patients are needing transfusions?
Yes, so there are lots of kind of anemia-directed therapies in myelofibrosis that are being looked at. Um, One is a drug called luspatercept, which is approved for myelodysplastic syndrome with anemia, and there have been studies to kind of look at its use in myelofibrosis as well. I'd say on average, depending on the study and the drug, like somewhere in the neighborhood of like a quarter to 40% of patients have either a reduction in their transfusions or their transfusions go away for several weeks. But as of yet, I would say we don't have any slam dunk therapies that are either in clinical trials or standard therapies that get rid of the need for transfusion in over 50% of patients or anything like that.
Okay. And then this is a really good, just general question. But so this individual is seeing a general oncologist. But what are some questions that you think would be good for them to discuss with their oncologist at their next appointment, just to really make sure that that oncologist is aware of some of the like different subtleties of
Yeah.
these MPNs?
So, I mean, I think in general, the framework I think about is, what is the type of MPN I have? And can you kind of pin that down for me? Why am I taking the treatment that I'm on? So if someone's on, say, hydroxyurea, Jakafi, et cetera, like, the oncologist or hematologist should be able to very definitively say, we started this medicine for this reason. Sometimes there isn't a good reason to be on a medicine, and it should then be stopped if that's the case. And then the other question I would ask is, which MPN experts have you worked with in the past, and do you mind reaching out for a referral? The other thing to think about is distance-wise, if it's someone that's far away, perhaps, a lot of times, for example, within the state of Illinois, I'm able to do video visits. I'm not able to do them over the state borders, given kind of a lot of regulations that were relaxed during COVID that are back. But even within your state, that there is an opportunity to seek out video visits if you can't physically travel somewhere.
And I think that I'm so happy that you highlighted that one because that's something that I hear a lot of these individuals maybe living several hours from these specialty sites. Um, they might not always be able to or able to frequently visit a specialty clinic. So knowing that often those telehealth video visits are an option for them, not in every case, but in a lot of cases, I think can really help a lot of people and they just may not be aware of it. So thank you so much for highlighting that one. And then this individual just wanted clarification on going back to the cancer versus autoimmune fibrosis. So the way to distinguish that is chromosome and molecular testing, correct?
Yes, and ideally done at time of a bone marrow biopsy, although sometimes those tests can be sent from the blood as well.
Okay. Um, this person trying to like make it not overly specific, but make it a little bit more general. So, um, but if an individual is not on any medication, but they experience a pretty drastic drop in a blood count, in this case platelets, going from the mid 600s to about 400, is a drop like that considered a red flag? If so, what could that signify?
Yeah, I mean, so one thing I'll say is that the platelet normal range is quite big. So a normal platelet range is essentially anything from 100 to 450. And you can have kind of very broad fluctuations even within that range. So a drop from 600 to 400, I would just keep a close eye on, but not necessarily do anything about it. And on the other hand, if someone's uh, platelet count had dropped down to like below 100 or something, then you really want to ask, what's going on?
Okay. Then this one comes in from YouTube. How do you approach a single hit to 53 mutation in myelofibrosis? What allele burden of TP53 is concerning, and is there a place for IGF-1 inhibition in myelofibrosis?
Yeah, so in terms of the TP53 part, so TP53 is a high risk mutation that's seen in a variety of different cancers, including myelofibrosis. In general, we differentiate between single hit TP53, meaning only one copy of your TP53 is knocked out, versus multi hit, meaning both copies of your TP53 are knocked out. And broadly speaking, in patients with single hit disease, meaning they only have one copy knocked out and the percentage of the mutation is typically less than 40% or so, they tend to do as well as those that don't have a TP53 mutation at all. But for people that have what we call multi-hit disease, we do worry about there being a higher risk of them not responding as well to disease directed therapies or transplant or those sorts of things.
Um, And then another kind of broad one that I really like, but so are there benefits to early treatment for CALR or just in general with mostly normal blood work and splenomegaly? So not elevated blood counts, but enlarged spleen. Are there early treatments that could be beneficial for these individuals?
Yeah, so that kind of gets back to that question of disease modification, meaning, early treatments are really only worth pursuing if you think that those early treatments are going to reduce your risk of progression or potentially get rid of the cancer cells. So for the CALR targeting therapies, actually there is some thought about, for example, using them in things like ET to be able to kind of knock the disease out early, hopefully. And again, that's the intent. We don't know yet if that's what these CALR therapies will do. That's why they're being studied, but that's something to keep in mind.
Okay. And then another mutation question. What does a TET2 mutation alongside a JAK2 mutation mean? Is that going to be different than just a standalone JAK2 in terms of prognosis, or are those kind of viewed in the same
Yeah, so
bucket?
so a TET2 mutation is not used in our prognostic scores, and a TET2 mutation is actually can even be seen in older individuals without any blood cancer at all. It can be what we call a CHIP mutation, meaning a mutation that just develops over the course of life without being associated with a blood cancer. So TET2 in general is not something that we incorporate into our decision making.
Okay. And then this will probably end up being our last question just due to time, but so this individual has been given a Retacrit injection in the past to help deal with anemia. Are there any other options that could help manage anemia a little bit better, though?
Yeah, so I mean, I will, depending on the reason and indication and what disease someone has. So momelotinib is the JAK inhibitor that's been specifically kind of developed for myelofibrosis with anemia. So that's an option if someone has myelofibrosis and anemia. There's that medicine luspatercept I mentioned, which is approved for myelodysplastic syndrome with anemia, but sometimes can even be administered to patients with MPNs if needed, and if insurance will approve it. But it's not approved, FDA approved for that indication. So those are a couple options.
Okay. And then I lied. We had one last question sneak in, but it's a good one that I think a lot of people would be interested in. But can a diabetic be eligible for a stem cell transplant?
Yeah, the short answer is yes. So in general, chronic medical conditions don't specifically knock you out of being eligible for a transplant as long as those medical conditions are well controlled. And the same goes for diabetes.
Okay. Excellent. Thank you so much for your presentation, and thank you for staying on and answering all of these questions. It was so wonderful to work with you again. It's always a pleasure.
Thanks. Y'all have a good one.
You too. All right. And as we start to wrap up here today, I wanted to let everyone know that we do have a couple of other events coming up. So first off, we have a chair yoga or I guess that'll actually be a little bit later, so I'll skip to this one. But this is going to be a bi-monthly cancer financial Q&A. So this is one of our financial coaches helping answer your questions about treatment costs, support, things like that. And that'll be happening on August 5th. And then we also have a chair yoga for energy, strength, and serenity for those with blood cancer. This will be led by a blood cancer patient. So really tailored towards the blood cancer community to help get some movement going and really help people find a sense of peace through movement, in this case, yoga. And that'll be on August 20th. So you can register for either of those on our website. We're always working on developing more. So there are more to come. I just wanted to flag those ones for the community. And as you leave today, a quick reminder, we are going to be doing our little talk after the fact. So if you want to stay on to chat with one another, I would love the opportunity to speak with all of you. Question that we're going to be discussing is, what would you tell someone who is newly diagnosed? If you aren't able to stay on, I totally understand. We do still have that survey available for you. So if you take just a moment to fill that out, it is very, very helpful. And then I'm going to go ahead and launch our poll now, so long as I can remember how to do it, so that we can also cover the results of this poll during our little chat time at the end. This poll is going to be asking about what stage of diagnosis are you in. One other thing that I want to let everyone know about before we hop off here is our new Connect to Cures program that we're running here at HealthTree. This is an opportunity for you to connect with blood cancer patients in your community. So these are free in-person events. We have one happening this weekend in Harrisonburg, Virginia. So if you're in that area, like, please check it out. These are really cool events and a really cool opportunity for you to meet other members of the community. But we also have events coming up in San Jose, Las Vegas, Grand Rapids, Austin, Texas, Spokane, and Brooklyn. So definitely check those out if you are in the vicinity. And finally, I want to just say a big thank you uh, to everyone here today for being part of our community. Big thank you for Dr. Patel for sharing your time with us and giving us a very informative presentation. My email is on the slide here. If you ever want to reach out, have any questions, anything like that, I am always here for the community. It's just Dalton, DALTON at healthtree.org. And please reach out to me with any questions that you have. Um, I appreciate each and every one of you. I hope you have a wonderful rest of your day. And I'm going to go ahead and turn off the live stream and the recording so that we can get into our um, just conversation piece here at the end. So give me just one moment to do so. And Marisol, can you confirm if we are no longer live streaming?